Good morning, everyone. Welcome to our first talk in the September Symposium series with Dr. Michelle Fallard, speaking for us today on women and Parkinson's disease. My name is Alana Dillon. I'm an Education and Support Services Coordinator at Parkinson's Society BC, and I'll be facilitating our webinar today. Before I introduce Dr. Fullard, I'd like to go through a few housekeeping items with you. First, I want to let you know that we are recording this webinar and it will be available on our website. Secondly, you will see a chat icon at the bottom of your screen. If you click on that icon, it will expand and the window will open up, and you can use this chat box to type your questions for Dr. Fullard or any comments for her, and she will address them at the end of her talk in the Q&A session. And then finally, to optimize your experience with this webinar, please do ensure that you adjust your speaker volume both on your computer as well as on your actual speaker so that you can hear the webinar well. Also, I do want to mention that at the end of the webinar, please wait for a pop-up window for the webinar feedback questionnaire evaluation form to fill out. Your feedback is always important to us, so if you have a few moments to complete that for us, that would be great. It's my pleasure now to introduce Dr. Michelle Fallard. Dr. Fullard is a movement disorder neurologist at the University of Colorado. She completed her undergraduate and medical school education at Vanderbilt University. Following medical school, she completed her neurology training at the University of Virginia and movement disorders training at the University of Pennsylvania. During her fellowship, she also received a Master of Science in Clinical Epidemiology. In 2018, Dr. Fullard joined the faculty at the University of Colorado, where she is the Director of Research for the Movement Disorders Division. Her research focuses on gender disparities in care for women with Parkinson's disease. Thank you for being here, Dr. Fullard. I will pass it over to you now.
All right, well, thank you, and thank you for having me. So we'll be talking all about, what we know about the differences between men and women with Parkinson's, and talking about some women-specific issues. So just to go over, actually, I don't see my slides advancing. Let's see if I can get that there. Okay, there we go. So, we'll talk about just some basic definitions first, and then we'll talk about the differences in risk factors for Parkinson's, the role of estrogen, and then we'll talk all about the differences in men and women as far as the symptoms go for Parkinson's. And then we'll get into differences in access to care and then research. And you might be asking, why is it really important to know about these gender differences? Well, for one, we want to be able to tailor treatment for women and men with Parkinson's. So knowing the differences will allow us to do that. And then it can also help us, predict how someone with Parkinson's will do, and then help us meet their individual needs. So we'll start with some of these definitions. So when we talk about sex, we're talking about biological sex. So XX chromosomes, XY, and that has implications for how someone might respond to treatment. And while it's related to gender, it is different. So gender is more how someone identifies. Do they identify, as a woman, or it can also have implications for, the role that they take on in their family, in society. So in the medical literature, we actually see these used interchangeably. And again, while they are related, they are different. So we'll actually talk about the two of them today. So one of the most well-established differences between men and women in regarding Parkinson's is just the epidemiology of Parkinson's. So we know that men are at higher risk of getting Parkinson's in general. So overall, if we look at the how many people have Parkinson's in the world, it's about 10 million. If we look in the US, it's about 1 million, and in Canada, it's over 100,000. And then if we look at how many men and women have Parkinson's, the incidence, so that's the rate of diagnosis of Parkinson's, is about 1.4 to 1.5 times higher in men. So that means for every 3 men who are diagnosed with Parkinson's, about 2 women will be diagnosed with Parkinson's. And then when we talk about prevalence, that's talking about, if we look at everyone with Parkinson's now, or everyone in the world now, how many have Parkinson's? And that also is higher in men. And what we'll also talk about a little bit later as well is there's some evidence that women may develop Parkinson's a little bit later than men, which can also affect the prevalence at any given time. And, when we think about the incidence, the prevalence of Parkinson's, it also increases with age. And so that's what you can see in this graph here. So as the age group gets, or as the group gets older, you have a higher risk of Parkinson's. We typically think about the age of 60, 62 is when people are diagnosed. And then as people get older, the risk of Parkinson's increases. The lines are similar for men and women. So as people get older, both men and women are at higher risk of developing Parkinson's, but the risk remains lower for women throughout every age group. So if we think about risk factors for Parkinson's, there are some factors that seem to decrease the risk of people developing Parkinson's, and then those that increase the risk. And these seem to be a little bit different for men and women, mostly due to actual exposure to some of these risk factors. And then a lot of the studies that have been done on these risk factors involve mostly men, especially when we're looking at jobs that can increase your risk for Parkinson's. So some of the factors that can increase your risk for Parkinson's includes head trauma and pesticide exposure and farm living. There's some evidence that people who have more dairy in midlife are at a bit of a higher risk of developing Parkinson's. And then there are heavy metals, Agent Orange for those who are in Vietnam can increase your risk for Parkinson's. And then what we found in studies and just in general is that men may have more frequent occupational or recreational exposure to some of these risk factors. So that might explain some of the increased risk that we see in men. Now, if we switch over and look at the factors that are associated with a decreased risk, those can include smoking, which we definitely don't recommend smoking to decrease your risk for Parkinson's, but an association that has been found. Coffee intake or caffeine intake. Some studies that is also true for women, but for the most part, the association has mainly been seen for men. So higher caffeine intake earlier in life can be associated with a decreased risk of Parkinson's later on. And then for both men and women, we do find that those who are more physically active in midlife, earlier in midlife, do have a decreased risk of Parkinson's. And then there are some other interesting factors that decrease your risk as well. So those who use more, we call NSAIDs or non-steroidal anti-inflammatory drugs, so things like Motrin, ibuprofen, those seem to decrease people's risk for Parkinson's. In most of the studies, though, that has only been true for men. And then more recently, we found that high urate levels can decrease your risk for Parkinson's. So urate is something that can be found to be high in things like gout, kidney stones. And again, this is one that's only true for men in the current studies, but men who had higher urate levels had a decreased risk for developing Parkinson's. If a man with high urate did go on to develop Parkinson's, they tend to have fewer symptoms and slower progression than those with lower urate levels. And the thought is, you might be asking, why is that not true for women as well? Well, we'll get into it a little bit, but it does seem that estrogen can be neuroprotective and have a protective role for decreasing the risk of Parkinson's among women. So it's thought that estrogen has such a neuroprotective effect that any effective urate wouldn't give any additional decreased risk of Parkinson's. But again, more studies are needed, but most of the occupational studies have been done for men. So what we do know, again, farming, pesticide exposure, repeat concussions or head trauma can be associated with that increased risk. The only study that's been done in a large group of women has shown a slightly increased risk for Parkinson's for women who work in healthcare, teaching, and social work. But this study didn't collect any information on any of these potential exposures. So we don't really know why that association exists. And right now it's pretty small. So we really need more work done in this area to figure out other potential risk factors for Parkinson's. So then something else that can increase your risk for Parkinson's are certain genetic mutations. So one in particular, LRRK2, is one of the more common genetic mutations associated with Parkinson's. And as with most of the genetic mutations that are associated with Parkinson's, they have what's called reduced penetrance, meaning you might have that gene mutation, but 40% of the time someone would go on to develop Parkinson's. So having that gene mutation doesn't necessarily mean that you'll go on to develop Parkinson's. But what some studies have found is that if we look at a whole group of people with Parkinson's and a LRRK2 mutation, that women are actually more likely to have that LRRK2 mutation than men. This is found in Italian populations, Ashkenazi Jewish populations, and then across North America as well. So there is some thought that, because like we were talking about before, men might have more occupational exposures or recreational exposures that increase their risk of Parkinson's compared to women, that then it might be more of the genetic risk factors that we see in women because they don't have as much of that environmental exposure. This is all still more of a hypothesis, but more study is ongoing. And then in some studies, if we just look at women and men reporting a family history of Parkinson's, it does seem like women report a family history more often than men. So that's suggestive of potentially more of a genetic risk factor for women. But again, these studies are on the smaller side when we're thinking about genes and genetic mutations. And if you look here in this table, about 18% of the men reported a first, second, or third degree relative with Parkinson's compared to 22% of the women. So not big differences, but still a difference there. And then one of the other genetic mutations that's associated with Parkinson's is GBA. And these studies have been a little bit inconsistent. A lot show that having a GBA mutation in Parkinson's is the same between men and women. Some have shown that women are more likely to have GBA mutations, but more recently, it looks like men actually might have more. So that's, again, some of that inconsistency that we see. The most consistent finding is this LRRK2 mutation might be more common in women. So now we'll shift into more of some of the issues that are specific to women with Parkinson's and the role of estrogen. So when we think of biological sex, we know that there are differences in hormones. So women will have different exposure to estrogen throughout their lifetime, whereas men have more of the exposure to testosterone. So if you look over at the graph over here, you can see, around the time of puberty, women have an increase in estrogen, and it'll be throughout their fertile lifespan. And then when they start going through menopause, estrogen decreases. And it's also during menopause that we tend to see women developing Parkinson's. So it's thought that, earlier on, estrogen might be protective. And then as estrogen drops, you lose that neuroprotection and you're at more risk for Parkinson's. And other things that we find, so looking at the basic science research in animals, those who are exposed to various injuries to the dopamine system, if you expose them to estrogen first, it actually protects those neurons. So there's some evidence from the animal studies that estrogen can be neuroprotective. And then if we look at studies of what we call cumulative estrogen exposure throughout a lifetime. So women who have later menopause, they seem to be at lower risk of Parkinson's. And if they do develop Parkinson's, the age of onset seems to be later. So again, suggesting that there could be that neuroprotection from estrogen when you're still exposed. And then in a study of about 5,000 women who had an oophorectomy, so meaning that their ovaries were removed, and so then they would go through surgical menopause, and that would be before their natural menopause, they actually had an increased risk of Parkinson's. So going through menopause early, having decreased estrogen exposure, again, may increase your risk for Parkinson's. And this is also true in studies who look at people who have natural menopause. The later you have menopause, the less likely you are to develop Parkinson's. And again, these are all more just association studies, but that is one of the more consistent findings. So because we have this evidence that estrogen might be neuroprotective, you might be asking, well, then why don't we give people estrogen, if that will decrease their risk for Parkinson's, which is, definitely a question that has been asked. One of the problems is hormone replacement therapy or estrogen replacement therapy can have a lot of side effects. It has effects in the brain and then outside the brain as well. And so before we can recommend it for Parkinson's, we really need evidence that it is helpful without causing too many side effects. However, there are people who go on hormone replacement therapy for other reasons, and some do report that their Parkinson's symptoms actually improve. And if we look at, we'll talk about DAT scans a little bit later, but DAT scans are something that show basically the integrity of the dopamine system deep in the brain. And looking at people without Parkinson's who are on hormone replacement therapy, they actually have an increase in DAT binding. So they have a more robust dopamine system. So again, suggesting that estrogen interacts with the dopamine system and can be neuroprotective. So again, we'll talk a little bit more about this, but at this time, we don't have enough evidence to recommend hormone replacement therapy. But that being said, if it is recommended to you for other reasons and you do have Parkinson's, you again might notice some improvement in your symptoms. But we do need more studies to really see how much it improves symptoms, if it really does over time, and if it is safe over time as well. So some of the other issues that are specific for women with Parkinson's, while not as common, we do still see about 3 to 5% of women diagnosed with Parkinson's under the age of 50, and many are under the age of 40. So they may still be having menstrual cycles. Some may be contemplating pregnancy. And so they'll have potentially additional issues related to hormones and estrogen and how it interacts with Parkinson's. So if we look at a typical menstrual cycle, you'll see here in the pink or red, this is the level of estrogen throughout the 28 days. And so it tends to peak in the middle of the cycle and then decreases until about day 28, and it's at the lowest during menstruation. So what some people with Parkinson's find is that right before menstruation and during menstruation, they actually have an increase in their Parkinson's symptoms. And some will also notice that they might be taking their normal Parkinson's medications, but it just doesn't seem to be working as well. I have some patients tell me that they're taking their Levodopa, but it just doesn't feel like it's kicking in. It's not really lasting very long, and just not working as well as other times during their cycle. And along with this, women can notice an increase in off time. So, if you are noticing any of these symptoms around the time of your menstrual cycle, there are some things that can be done to try to reduce some of this increased symptom burden. So some people, if they're not trying to get pregnant, will go on oral contraceptive pills because that will keep the estrogen and progesterone levels relatively level throughout the cycle. And then that can decrease some of that increase in Parkinson's symptoms. That works for some people, for others, fewer, but some do notice that going on those oral contraceptive pills actually worsen some of their symptoms. So it is a little bit of trial and error. But if that doesn't work for you, then something else that can be tried is just during those few days or even up to 7 days, increasing the amount of levodopa or your other Parkinson's medications. And for some people, that does help quite a bit. And again, these are things that your physicians may not be thinking about if you haven't told them. So if you're noticing anything like that or fluctuations in your symptoms around your cycle, definitely something to mention to your doctor, and maybe a discussion between your neurologist and your gynecologist. And as I mentioned before, since there are about 3 to 5% of people who are diagnosed with Parkinson's under the age of 50, then some may be contemplating pregnancy as well. So we really don't have a lot of information about pregnancy and Parkinson's. Most of what we know is from about 114, 120 people with Parkinson's who did have successful pregnancies. But what we have found from studying these cases is that there doesn't seem to be any differences in fertility compared to those without Parkinson's. But what we do find is for about half of the people or women with Parkinson's who do get pregnant, about half will notice that their Parkinson's symptoms worsen. So they might have an increase in tremor, increase in stiffness, increase in slowness during this time. And of those women who do notice an increase in symptoms, about a third will notice that symptoms improve if they increase their levodopa medication. But for the other 2/3, the medication doesn't work as well for that increase in symptoms. So again, that would be working with your doctor to try to see if other medications could be helpful or potentially adding new medications. But we do know that if we look at fetal and maternal outcomes for people with Parkinson's, it's very similar to people without Parkinson's. So no big differences there. But when we think about pregnancy, one of the big questions is what medications are safe? What we do know is that levodopa, or carbidopa levodopa, one of the main medications used for Parkinson's, does seem to be safe. That was used in 114 cases, women with Parkinson's, and then women with other disorders, might be things like restless legs, and that there was no increased rate of birth complications or birth defects, and no increased rate of miscarriage. So usually that is the medication that's recommended for women who are pregnant with Parkinson's. Other medication classes like dopamine agonists, fewer women have taken that in pregnancy, at least as far as has been studied. It does seem that there's no increase in birth defects with dopamine agonists. But in the small study, and again, this was only 35 people, there was potentially an increase in miscarriage, although too small of a sample size to really know. Otherwise, there was, again, no increase in birth defects. So it seems possibly safe, but we really need more data. And then amantadine is a medication often used in Parkinson's for dyskinesia, can also be helpful for tremor. And we do know that it can increase the risk of birth defects. So for any woman with Parkinson's considering pregnancy or who is pregnant, they should not be on amantadine, and that's one that should be avoided. And then for other medications like the COMT inhibitors, the MAO-B inhibitors, so things like selegiline, rasagiline, we really just don't have the data to know whether or not it would be safe in Parkinson's. But this is another case where it would probably be a collaboration between your OB and your neurologist, figuring out what would be best for you during your pregnancy. And then once we get past the fertile years and we're going into menopause, we also see other effects of estrogen on Parkinson's disease. So if you look here, we see that the amount of estrogen that women are exposed to starts to decrease around the age of 40. You see a much bigger decrease around the age of 50, and then will continue to decrease throughout the lifetime. And what we found in survey studies is that at least 43% of women note that their symptoms worsen when they stop having menstrual cycles. So when they start going through menopause, they notice that Parkinson's symptoms are worsening. And it's thought that this is due because of that drop in estrogen that you see with menopause. And again, we talked a little bit about this before, but it's unclear if hormone replacement therapy can improve symptoms. There have been some small studies. One, the Poetry trial, and involved 23 women with Parkinson's who were given hormone replacement for 8 weeks. And they did have an improvement in their motor scores. So improvement in slowness, stiffness, and in tremor. But again, this is a very small study and only for 8 weeks. So we really need bigger studies to see if that improvement is sustained and to see if it's safe over time. Another issue that can come up with menopause and Parkinson's. So as we were talking, a lot of women with Parkinson's are diagnosed after menopause, and there can be some confusion between the symptoms of menopause and Parkinson's. And some of those can include fatigue, depression, increase in sweating that can occur in both conditions. So if Parkinson's is developing at the same time as menopause, it can cause a delay in diagnosis. So one of the reasons to make sure you're letting your doctors know about potential symptoms. If there are other symptoms that are developing, slowness, decreased arm swing, definitely a reason to see a neurologist. And then for any women in general, osteoporosis can happen after menopause as well. But we do find that women with Parkinson's have higher levels of osteoporosis. So it's going to be lower bone mineral density, which can lead to higher fracture risk or higher risk of breaking bones. And so because of this, once women are at the age at least of 60 or going through menopause, it would be a good idea to talk with your doctor about whether you need a DEXA scan or some kind of screening for osteoporosis, because we definitely want to try to prevent fractures as much as possible. And women and men with Parkinson's are going to be at a higher risk of fracture in general compared to people without Parkinson's. And then lastly, just talking about sexual dysfunction in women with Parkinson's. So sexual dysfunction can happen in women and men. Specific to women, some will notice low libido, some may notice difficulty achieving an orgasm, vaginal dryness, pain with intercourse can happen. A lot of these are thought to be due to the decrease in estrogen that comes along with menopause. And so some of these are not necessarily Parkinson's specific. But what we found from other studies and just talking with women, women with Parkinson's can develop some trouble with self-image, which can also affect intimacy. And then, of course, the motor symptoms of Parkinson's, so slowness, stiffness, can also affect intimacy and make it more difficult. So there are treatment options available, and definitely something to talk with your doctor about if you're noticing any of these. And for some women, even just timing intercourse for when Parkinson's symptoms are well controlled can be helpful as well. All right, so we'll switch gears a little bit and go into the differences between men and women as far as symptoms go with Parkinson's. So when we talk about prodromal Parkinson's, we're talking about the symptoms that occur before somebody is diagnosed with Parkinson's disease. And these can be things like loss of sense of smell, constipation, acting out dreams, even depression, anxiety can come on before the actual symptoms of Parkinson's. So the motor symptoms are usually how someone's diagnosed. Again, what we've talked about, tremor, slowness, and stiffness. And even 10, 20 years before people are diagnosed, they can have some of these other symptoms. So there was a group in Germany who followed people over time, just looking at symptoms, not necessarily Parkinson's specific, but they did look to see who developed Parkinson's over time. And what they found were that women before developing Parkinson's had a higher incidence of depression, and then a higher incidence of what we call subthreshold Parkinson's before they were diagnosed with Parkinson's compared to men. And the subthreshold Parkinsonism is, you might have a little bit of slowness, maybe you're not swinging your arm as much, but you don't meet criteria for Parkinson's at that time. And so some people can have subthreshold Parkinsonism, maybe a year or so before they're actually diagnosed. Otherwise, symptoms seem to be pretty similar between men and women. With Parkinson's, there might be more olfactory loss or decreased sense of smell in men, but otherwise those prodromal symptoms tend to be relatively similar. And then once we get to a diagnosis of Parkinson's, when we think about the motor symptoms, we find pretty consistently that women tend to have more tremor than men with Parkinson's. There's some inconsistency about postural instability, so talking about balance. Some studies have found that women have more imbalance or more of that postural instability than men. Others have found no difference. In many of the studies, though, we have found that men have more rigidity, so more of that stiffness in the arms, the legs, the neck, and might have more difficulty with writing and clumsiness. But again, as you might hear as a theme, some of these studies are just inconsistent, and some studies haven't shown any difference in these symptoms. But overall, it does seem that tremor is more common in Parkinson's. There's also been this question of, do women have a more benign phenotype, meaning is their Parkinson's more mild compared to men? And there's some evidence that at least maybe in the beginning that might be true. So tremor predominant Parkinson's in general is associated with a slower motor progression for Parkinson's. And since women are more likely to have tremor, that might contribute to potentially this more benign phenotype or more benign symptom course. However, we do know that women can have more non-motor symptoms that we'll talk about, and that can really affect quality of life and kind of goes against this more mild Parkinson's for women. And then we'll also talk about a little bit too, but women are also at a higher risk for levodopa complications or side effects from carbidopa levodopa and are more likely to develop dyskinesia compared to men. Now, if we look at progression, especially in early Parkinson's, a recent study using data from the Parkinson Progression Markers Initiative, or PPMI, through the Michael J. Fox Foundation, found that in the first few years of Parkinson's, men actually reported more progression in their motor symptoms. And then if we look at the actual scores that the neurologists were giving them when they were on medication, their scores were actually higher than women. So it did seem like they had more symptoms. And then following them over these years too, they also increased their carbidopa levodopa faster than women. So it seemed like they had more of a need for more medication and their scores were a little bit higher than men. So again, going along with that potentially slower progression of motor symptoms for women, maybe more benign disease course, at least in the beginning. But when we look at off motor scores, so when men and women were off of their Parkinson's medications, the scores were similar between men and women. And other studies looking at not necessarily early Parkinson's, but more mid Parkinson's, found that the motor scores were pretty similar between men and women. Now, if we look at progression in non-motor symptoms, men had more rapid progression in urinary symptoms. So things like frequency, urgency, and potentially some urinary incontinence or accidents would progress more quickly in men. Men were also more likely to develop lightheadedness. So when they stand up, feeling like they're getting lightheaded, like their blood pressure is dropping, and then had more progression and fatigue over the first few years of the disease. So I mentioned DAT scans before, but some of the research, especially in PPMI and others, is trying to figure out how we can compare things like the DAT scan to progression over time. And can we predict progression based on people's DAT scans? So if you're not aware, a DAT scan involves the injection of a radio tracer. So it circulates throughout the body and then makes its way to the brain where it attaches to the dopamine transporter. And these dopamine transporters are found on dopamine neurons. So it's a way to kind of visualize the dopamine system deep in the brain. And these scans can be helpful for diagnosing Parkinson's if there's a question of atypical symptoms, atypical features. Otherwise, in general, we can usually diagnose Parkinson's clinically, based on what we see on your exam. But when we look at these DAT scans, so the one over here on the left is normal. So you kind of have these comma shapes on each side. And then on the right side is the DAT scan of someone with Parkinson's. So you lose some of that binding from losing dopamine neurons over time. So what some studies have found is that women tend to lose that binding to the dopamine transporter slower than men. So they have more of that binding over time compared to men. And this again has led to that suggestion that women have slower progression. But what we don't know is really how this compares to actual progression of motor symptoms. But there's just that question of, is estrogen neuroprotective, and is there a decline that's slower in women because they're losing dopamine neurons at a slower rate? However, more recently, again, looking at early Parkinson's, when the researchers looked at the tracer binding over 5 years, it looked like the decline was similar between men and women. So again, somewhat inconsistent, but women, at least earlier on, might have a bit of an increase in that binding compared to men, but there might be a similar decrease over time. So if we switch over to non-motor symptoms, so these are symptoms that aren't the slowness, stiffness, or tremor, but are associated with Parkinson's and can come along with Parkinson's and oftentimes affect quality of life more than the motor symptoms. So some of the differences that we found between men and women include an increased incidence of depression and anxiety in women, There's some question, depending on what study you look at, some women might report more constipation and GI symptoms, although in some studies that's been found more common in men. More consistently, though, we find that women report more pain, more fatigue at any given time, and are more likely to have restless leg syndrome symptoms. And then, if we look at fluctuations, often when we're talking about fluctuations, we think of motor fluctuations. So you take your levodopa, it kicks in, it starts working, and then the effect might wear off before your next dose. So maybe tremor comes out, slowness or stiffness worsens before your next dose. Well, there's also something called non-motor fluctuations. And that's where when your medication is working, maybe anxiety is better controlled, depression is better controlled, but then as the medication wears off before your next dose is due, you might have an increase in that anxiety or an increase in depression or fatigue. And women seem to be more prone to these non-motor fluctuations. And that's where even just an adjustment in medication can help with some of those symptoms. As far as men go with Parkinson's, they are more likely to have the orthostatic hypotension. So that's the blood pressure dropping when you stand up, getting lightheaded. If it's severe, can lead to falls. Again, depending on the study, men might have more urinary symptoms, some more of the frequency, urgency. Pretty consistently, men do report more REM behavior sleep disorder or that acting out of dreams. And we also find even when we look at men and women who do have REM behavior sleep disorder or dream enactment, men tend to have more violent dreams, fighting dreams, and are more likely to knock things off the nightstand or fall out of bed, whereas women are more likely to report just a disturbance in sleep, but tend not to have as much of the violent movements. And then in most studies, men do report more drooling and do have more cognitive impairment compared to women, some trouble with memory and thinking, and then often report more sexual dysfunction and daytime sleepiness compared to women. And it's important to know not only about these potential differences, but just that these symptoms can be associated with Parkinson's. Because I find, especially when I'm meeting patients for the first time, they may not be aware of all the symptoms that go on outside of the motor symptoms, but your neurologist can help address these symptoms. So it's important that you're bringing these up to your doctor. So as I mentioned, men do have an increased risk of memory and thinking trouble in Parkinson's. And we see a similar pattern outside of Parkinson's. So men in general have more trouble with verbal memory. So if someone gives you a list of words to remember, they might have more trouble with that. They have more trouble with executive function. So that's things like working memory, keeping things in your mind for a short period of time, organizing, planning, completing tasks can be more difficult for men with Parkinson's. And then for Parkinson's and then in general, women tend to have more difficulty with visuospatial cognition. And what we find if we look over the lifespan of Parkinson's and compare men and women, again, men do tend to be at a higher risk of developing the memory and thinking trouble. They're at a higher risk of dementia associated with Parkinson's. But over time, once we get to about the age of 80, it seems like the risk of memory and thinking trouble is at that point pretty much the same between men and women. So again, there's some thought that maybe there's some estrogen effect on cognition as well. And then we talked a little bit about this before, but as far as treatment goes and side effects, there can be some differences between men and women. So for the dopaminergic medication, so thinking mainly about carbidopa levodopa, but also the dopamine agonists like pramipexole, ropinirole, men and women usually are treated with similar medications, but in general, the medication doses are lower for women. Some of this seems to have to do with body weight. In general, women weigh less and have lower BMIs than men, but it's not the whole story. We actually find, for similar weights, if we give a man and a woman 100 milligrams of levodopa, women will get a higher maximum concentration of the levodopa in their blood, and it will stay around longer. So it does seem like there's less clearance and just more overall availability of the levodopa for women, which might actually contribute to some of the side effects that we see as well. And then in general, as I mentioned before, women are at higher risk for depression and anxiety with Parkinson's. And they are more often prescribed antidepressants and benzodiazepines compared to men. And then as far as the side effects from medication, if we look at over time, in this figure here, the white part is what we call the therapeutic window. So that's when you take the levodopa, it's working well, and you're not having side effects, so not having dyskinesia, not wearing off. Early on, that therapeutic window is pretty large. And so we're not getting many of the off times, and we're not getting much dyskinesia. But that therapeutic window tends to narrow over time. So if you overshoot the window, you might get dyskinesia. And if you go under that window, then you might have off time or when the medication is not working well. Well, what we find is that women tend to have more dyskinesia than men. They develop it earlier. So on average, maybe at about 4 years compared to 6 years for men. And then they do tend to have more of the fluctuations, so that up and down with the medications, and then more wearing off. And that tends to occur earlier compared to men. And again, that time to dyskinesia is less for women compared to men. And then there's also this small subset of people with Parkinson's that are described as having a brittle response to levodopa. And so that's where even if they take a very small dose of levodopa, might be less than 100 milligrams, even a quarter of a dose of carbidopa levodopa, they can get very disabling dyskinesia. So all those extra movements that can cause a lot of trouble. And so what we find if we look at that group that's very sensitive to levodopa, has those disabling dyskinesias, the majority of that group is women. So some might have to do with that lower body weight with BMI, but it does seem that being a woman does increase your risk for having that brittle response. And then, there's this question of, are there genetic mutations that play a role in dyskinesia? So in the D2 or dopamine 2 receptor, there are certain mutations that seem to protect against dyskinesia, but only for men. So might also point towards why women might be at a higher risk of dyskinesia. And then as far as other treatment goes, you've probably heard, but exercise is one of the best things that you can do for Parkinson's. It's one of the only things we know that can actually slow progression of Parkinson's, and something you probably hear about a lot and is very important. But what we know is that not everybody with Parkinson's exercises. So if we look at data from a big group of people with Parkinson's, we find that if you're younger, you're more likely to exercise. And if you're a man, you're more likely to exercise. And the group that was exercising or less active were older women, so over the age of 70. And then we've also found that married men tended to spend longer time performing exercise, and that women might report, just more in general, more household duties, more caregiving time that might cut into their time that they would otherwise have to exercise. And what we've also found too, when we look at motivators for physical activity and exercise, in general, women have reported more motivation by enjoyment of the activity and social support. So if you find that that is something you enjoy, having the social support, then you might look into more classes geared towards people with Parkinson's. But one thing that we often say is, no matter what you choose to do, make sure it's something that you like to do, because it is a lifelong commitment and something you want to keep up. And so if that is, going to classes or anything specific, again, just make sure it's something that you like to do. But something that we'll have to look more into in the future is, what exactly are the motivators and how can we help people get past any barriers to exercise, since it really is one of the best therapies that we have currently. So one of the other therapies that we have is deep brain stimulation surgery. And at least over the past decade, really longer, we've known that women are less likely to get DBS compared to men. However, if we look at the outcomes, women and men have similar improvement in their motor symptoms. And we actually find that before DBS, women report lower quality of life, they report more disability from their symptoms. And then after DBS, they actually have a greater improvement in their quality of life and disability compared to men. So it definitely works well for women and may even work better in some areas. However, we're more recently trying to learn why women are less likely to get DBS. In a lot of studies, it's been patient preference, and women are more likely to have concerns about the risks of surgery. But there's still a lot to learn in this area, because we know that in general, women have less social support, more likely to live alone. So there might be other barriers to DBS that we can help women overcome so that they're able to get this therapy that we know works really well. And the other side of that too is, as we've discussed, women are more likely to get dyskinesia. They're more likely to have those ups and downs in their symptoms. And that's one of the main indications for DBS surgery. So one of the reasons that we definitely want to make sure it's available for women who are interested in DBS. And let's see. And as far as access to care, so if we look at women and men in general with Parkinson's, we find that a woman has a delay from the onset of symptoms to diagnosis compared to men. And then if we look at the onset of symptoms to their first visit with a movement disorder neurologist, there's also quite a bit of a delay there as well. So men tended to see a specialist after about 1 year of symptom onset, while women, it took about 2 years to get there. And a lot of that was thought to be due to a referral delay. Some, might come from the bias of the doctor. So again, there's just this perception that Parkinson's is mainly a disease in men, but of course we know it occurs in women as well. And then in general, women might be or have a decreased tendency to disclose or emphasize some of the symptoms that's bothering them. And so the physician may not be as aware of some of the symptoms that they're having. We've also found in some of our studies that women are less likely to see a neurologist for their care. And oftentimes it is the neurologist who's referring someone for DBS surgery. So that might be another reason women are less likely to get DBS. And then, in general, when men and women start developing symptoms of Parkinson's, oftentimes within 3 to 4 months, they do see their primary care doctor. So that is about, or very similar between the two. But again, it just seems to be more of that delay in getting specialist care. And some of the reasons that getting specialist care, so seeing a neurologist or movement disorder specialist, is very important is because there is an association with a reduced risk of hip fracture, a reduced hospitalization risk for PD-related illnesses, and then decreased skilled nursing facility admission for people who are seeing a neurologist with Parkinson's. So if possible, we definitely do recommend seeing a neurologist. And then we actually did a study looking at who with Parkinson's disease in the US were seeing physical therapy, occupational therapy, and speech therapy. And so we found that women and men tended to use physical therapy and occupational therapy at the same rates, but women were less likely to see speech therapy. In some studies, we do know that men might have more of the hypophonia or decreased volume of voice. So that might be part of the reason. But women might actually be at a higher risk of dysphagia or trouble swallowing. But because of the data, we're not exactly sure why women were less likely to see speech therapy. And then we also know, just in general, for women with chronic illnesses, they're less likely to have a spouse as a primary caregiver. So some of this is, women are more likely to be single or widowed. Women tend to outlive men, so that is part of it. But in general, when we look at just chronic illnesses, there does seem to be a higher divorce rate when a woman has a chronic illness. So again, leads into more of a woman being single and living alone with Parkinson's and other chronic illnesses. And then we also find with Parkinson's that women are more likely to attend appointments alone and more likely to use a paid caregiver because they're less likely to have a spouse or a child as a primary caregiver. And then when we've spoken with women, many have said that they find it difficult to kind of reverse their role from caregiver to care receiver, because in general, women, do tend to take on more of a role of a caregiver in their families. And so, something we just recommend ongoing communication within the family and with their potential caregivers as well. And then just coming towards the end here, in one of the other studies that we did, we looked at how often women and men are using healthcare services after they're diagnosed with Parkinson's. And again, we did find that women were more likely to be admitted to nursing homes within 5 years of the diagnosis. We also found that looking up here at the top left, women were more or less likely to see physicians in their office, which might lead to potentially more use of other health services, potentially emergency room visits, hospitalizations, potentially because women have or are less likely to have a caregiver. They tend to use home health more often, and again, more likely to use skilled nursing facilities compared to men. And then something that we have also found and hasn't changed that much over the past decade or two is that women really are underrepresented in Parkinson's research. Most of the trials and studies going on in Parkinson's tend to be white males. And so we're working to figure out, what are the barriers to research for women with Parkinson's and what can we do to make research more accessible? Because it is through these clinical trials that we know, are these treatments effective for both men and women? Are side effect profiles different for women compared to men? So unless we have good representation of women in these studies, we really won't know as much about the effects of the medications or potential therapies for women. And if we look at, all the Parkinson's trials since about 2010, more than half were at least 59% men or higher, and often it is higher. But something that we are actively working on, and if you're not aware of research in your area, things like the Fox Trial Finder and clinicaltrials.gov are areas or places you can go to see if there are any trials in your area that you might qualify for. Because one of the benefits is that you may have access to therapies before they're even available. And then, there might not be benefits to you, but, it will contribute to Parkinson's research as a whole and hopefully to finding better therapies and potentially neuroprotective therapies for Parkinson's. All right, so I know we talked about a lot, and probably one of the themes was there's inconsistency in the results. There are a few things that we know for sure are different between men and women. So the incidence is higher in men, differences in risk factors. Women are more likely to get dyskinesia, but there's still a lot that we don't know. And so, where do we go from here with this information? So really, again, more research is needed in this area to really figure out what therapies are best for women. And especially, is hormone replacement therapy a safe and effective option for women with Parkinson's? And, would there be a role of it for men as well if it is neuroprotective? And then, overall, because women are less likely to see specialists, we need to figure out how to make access to subspecialty care more available to women and make sure DBS is available for women as well. And as we talked about, there are a lot of differences in the non-motor symptoms and then some issues that are specific to women. So we need to develop tools to track those symptoms that are specific to women and make sure they're able to show those symptoms to their physicians and discuss that with them. So, some things, at least right now, that you could do if you are a woman with Parkinson's, just make sure that you're communicating with your doctor about all your symptoms, because there are so many that can be associated with Parkinson's. And then make sure you're asking for help when you need it. Again, women tend to take on more of the caregiving roles, more of the household duties, but just make sure you're asking for help when you need it and surround yourself with those who support you. Definitely exercise, finding classes or exercises that you enjoy. And because women are more likely to attend appointments alone, see if there's a friend or spouse or family member who can come with you, not only just for support, but someone who can also ask questions and write things down. And then, see if some places have women's specific support groups that I have a lot of patients who go to, and they really like that extra support. So if there's anything like that in your area, that can be helpful. And then, learning more about research and how to participate can be beneficial, not only just for you, but, for women with Parkinson's in general. All right, so I will stop there so I can take some questions. Let's see here. So how severe of head trauma is common for PD risk? So with the studies, a lot of it is just reported head trauma. What we find is, the more head trauma someone has, so repeated concussions, some of them could be mild to severe, but it seems to be more repeated injury that increases the risk for Parkinson's compared to just one injury alone. And then how much exposure to pesticides is shown to increase the risk of Parkinson's, agricultural versus home use. So that's a good question. I don't know that we can really quantify it at this time, but we do know that farm living does increase your risk for Parkinson's. So we do think that the higher risk of exposure, on farms where you're using it a lot more and potentially much higher volumes, that does increase your risk. But what we also think is that there's an interplay between genetic risk factors and then exposures from the environment. Because if it was just these pesticides that were causing Parkinson's, then everyone living on a farm would have Parkinson's, and that's not the case. So we do think, again, that it's maybe some genetic predisposition, and then there's an environmental risk factor or some other exposure that then causes Parkinson's to develop. And then there's a question, what is visuospatial perception? So that's a good question. And women in general, even outside of Parkinson's, tend to have a little bit more trouble with visuospatial perception. But in Parkinson's, men and women do have visuospatial perception difficulties, but it's, again, more common in women. And so, this is the visual perception of things in your environment, or maybe being able to visualize where things are, or how to get from place A to place B on a campus or something. So being able to visualize that in your mind. So it's just the way you kind of orient visual things in your mind. And then there's a question, what are the first signs someone is developing dyskinesia? So dyskinesia in general is just these extra wiggly movements. They can happen on any part of the body. So some people will get them mainly in the head and neck. Some people can get it more in an extremity, so an arm or a leg. Some will get it mainly on one side compared to the other. But it's just these little small, in the beginning, kind of almost dance-like movements. And in the beginning, the person experiencing them may not even be aware of the movements. So it's usually a family member who points it out to them. And so oftentimes in the beginning, no treatment is needed because the person isn't aware of it. It's not bothering them. It's not harmful to them to be experiencing it. But over time, the movements can become present in other body parts and then can become bigger as well. So if you've seen Michael J. Fox give any interviews recently, oftentimes he tends to want to be a little bit more medicated. So he'll have more dyskinesia. So you could see an example of dyskinesia there. Let's see. Has there been a study where females with Parkinson's receive progesterone? So no studies I'm aware of just progesterone. There might be some who looked at women who were receiving progesterone, but most of it has centered around estrogen, since we do think estrogen plays a big role in potential neuroprotection and then the potential worsening of Parkinson's symptoms. So while some of the hormone replacement therapy is a combination of estrogen and progesterone, that has been looked at, but not progesterone on its own. But again, we really need those larger studies because most of them are 23 or up to 40 people. But to really know if it's effective, we need some larger studies. All right, under differences, there was an asterisk besides increased constipation, GI symptoms for women. So that was just meant to indicate that there's some inconsistency in the reporting of those symptoms. So there are some studies that show that constipation and those GI issues are more common in women, but then there are other studies that actually show those symptoms are more common in men. So compared to the rest on the list, those are a little bit less consistent.
Dr. Fullard, I just want to say that we're scheduled until 2.
Okay.
We're at 1:59. It used to be that if you went past 2 o'clock, it wouldn't close. Zoom wouldn't close, but I think they might have made some changes. I don't know if it applies to webinars or just meetings.
Okay.
So if it does, I want to say thank you so much for taking the time out to do such an informative talk for us.
Oh, yeah.
But it's 2 o'clock now, so it hasn't closed. So maybe you can answer the
Okay. Well, I think we only have one more question, but yes, thank you again for having me. So one of the questions, suggestions for dealing with fatigue or reduced stamina. So that's kind of a bigger question, because some of it is, what is actually causing the fatigue. We do find that it is more common in women in a lot of studies. But one, we want to make sure that before we say it's due to Parkinson's, that there's not anything else going on, so that thyroid's okay, kidney, liver, everything else looks okay. If it does, then we want to look at your Parkinson's medications, make sure we optimize them as much as possible. And then otherwise, fatigue is one of those symptoms that is really hard to treat in Parkinson's. We do try things like Amantadine can actually be helpful, but can also have side effects. And then for some people, even just caffeine can be helpful. And then we sometimes use stimulants as well. But a lot of it is a little bit of trial and error, because what works for one person may not work for others. And then trying to get into an exercise routine may help with fatigue and stamina, as long as you're not overdoing it. But a lot of that, is something to figure out in a discussion with your physician, because there are just so many things that can contribute to the fatigue. And then last question here, if hormone replacement therapy is started later in life, so well after a diagnosis, will it still be effective? So that's a really good question as well, and something we don't necessarily know the answer to. There is this question of, is there a critical time window for getting hormone replacement therapy to either decrease the risk of Parkinson's or decrease progression or help with the symptoms? And that window seems to be earlier on, so soon after menopause. But even though we don't have evidence, it's feasible that starting at any time could still benefit symptoms. May not necessarily be neuroprotective, because we still just don't know that in general. But it's possible that if you start hormone replacement therapy later on for any other reason, you may still notice an improvement in your symptoms. All right, so I think we've come to the end of the questions, but thank you all for those questions. Those were all great, and thanks again for having me.
Thanks again, Dr. Fullard, and thank you everyone for attending. Also, just I want to remind you that there will be a pop-up window. So before signing off, if you can please fill out that evaluation form that pops up. And also a friendly reminder that our provincial conference early bird discount is still on until the 14th of September. So you don't want to miss that early bird discount, and we would love to see you attend the conference. Thanks, everyone. Have a great afternoon and weekend.